Dear Chairman, dear colleagues and friends, dear ladies and gentlemen, it's a great honor for me to be in this way today with you. I apologize for not being in person with you, but hope that we can arrange this in the future. About myself, I'm Peter Schwarz. I'm Professor for Prevention and Care of Diabetes, and I'm the President-elect of the International Diabetes Federation. So I will become in April next year the President of the International Diabetes Federation. And this is my passion. This is where my heart is beating for, improving the care for people with diabetes, investing our knowledge and our enthusiasm into diabetes prevention, and to develop structures and role models for improving diabetes care worldwide. And with this lecture, I would like to touch some of the important topics, some of the challenges. And I just mentioned this, being the next president of the International Diabetes Federation and also a board member of the NCD Alliance gives an opportunity to learn a lot from the countries worldwide, but also to translate innovations from some place to the other place. But the important thing is the understanding about the quality of diabetes care in each of the regions. Today's situation is a challenge, and here you see 540 people on Facebook. All the red ones will develop diabetes, and this is the average prevalence of the population worldwide. If you go in some countries in your region, it's much, much higher, and we have to better understand why and to develop interventions to prevent diabetes from developing. But there's also a lot of hope on this slide, and these are the green ones. And the green ones, they do everything wrong like the red ones. They live in the same environment, have the same lifestyle, but never develop diabetes. So the green ones have something unique in themselves or in the behavior to prevent diabetes or being protected from getting diabetes. And understanding the difference between green and red would be one of the challenges in diabetes care in the future. But we have to understand where diabetes is coming from. And looking into the region, you see here the gray bar is the prevalence of diabetes in 1980, and the blue bar is the increase in prevalence due to the increase in population. This makes sense. But yellow and rosé, this is the increase in prevalence of diabetes due to the change of our lifestyle. And this is 70% of the current increase in diabetes is related to lifestyle change. But this also gives an answer because this is also the way how to prevent diabetes. Another way to look at it, if you look at this map, you may imagine that this is the red are the countries where the fastest gain in prevalence will occur in the future. It is not. It's the gain, or it's the today increase in air pollution. And I don't want to say that climate change is making diabetes, but if you breathe medium-sized particles, so it's if you stay behind a diesel car, yeah, you can find these particles 2 weeks later in the beta cell, and in cell cultures, this is destroying beta cell function. So air pollution may become a future health determinant for diabetes. And if you look into premature death, most of the common reasons for premature death are related to endocrine system, are related to metabolism, or climate and temperature. So this is something we have to address if you look into diabetes from a global scope. And as I said, for me, it's prevention of diabetes. This is my heart, there's my heart beating for, and these numbers are prevention of diabetes. If you would walk 10,000 steps from the age of 22, we would not get any chronic disease. And even better, if you have diabetes and you walk only 1,000 steps more, 1,000 steps is 600 meters. It's a short distance. That this 1,000 have an additional lowering of the postprandial blood sugar by 1.5 millimole. This is what 2,000 milligrams of metformin are doing. So this is powerful lowering of blood sugar. Unfortunately, this is European data, walk only 2,700 steps. We are lazy. We are made to walk 36 to 39,000 steps a day. Our muscles, our bones, our fascia, and we are not using it. And this makes us sick. If I ask the question the other way around, how many hours per day we are inactive, this is the answer. So we are a lazy species. But imagine the true diabetology is not in our brain as diabetologists. It's not our prescription as diabetologists. It's in the muscle of our patients if we would be able to activate this muscle. And of course, this is one of the challenges to address diabetes. But we are physicians, we are scientists, we have to understand pathophysiology. And here you see something healthy. Young women, nurse in our diabetes ward, green arrows means she's eating something she's always eating, has a high normal A1C and a totally flat glucose curve measured with CGM over 1 day. This is healthy. This is very insulin sensitive. She needs about 1% of her insulin to regulate blood sugar. Here is her father. Better A1C, slightly better, and 30 years, 40 years older. It's truly her father's 50% same genetic background. And you see a totally different curve. Yeah? This up and down, this is what was in the textbook 20 years ago. Today we know the father is very insulin resistant. He needs about 80% of its insulin to regulate blood sugar. And that's why this fluctuation starts, because if there is a load of glucose, the body cannot compensate very fast, as with the daughter, with the glucose load, and it starts fluctuating the glucose. Today we know that this fluctuation are relevant for morbidity and mortality of our patient. So imagine we have two people with an A1C of 7, one with mild fluctuation, the other one with big one. The one with the big one will die because of a stroke and a heart attack. This person has about 3 years to get diabetes, and then now maybe 9 to 15 years until we diagnose diabetes. So it would be perfect to do diabetes prevention in him, but we don't find him. The logical consequence for this, for us, for the future is we are not looking anymore only for A1C. We should treat the people or prevent diabetes by cutting the high spikes of glucose and cutting the low spikes of glucose. And this is relevant for prevention and care of diabetes and will be a challenge for future diabetes care. But going deeper into the pathophysiology, yeah, there is the gain in glucose defined as beginning of diabetes. There is the insulin resistance, the blue curve starting 20, 25, 30 years before hyperglycemia, proinsulin as a precursor for stress of the beta cell, transmitted all this by visceral obesity. Because the visceral obesity, the visceral fat depot is making us getting sick. Why? Because we know more than 800 peptide hormones released out of the visceral fat and acting in the whole body, increasing risk for depression, hypertension, metabolic syndrome, insulin resistance. So this is the target. This is I apologize for saying the devil if we talk about diabetes, but there's also someone else, and this is the hepatic fat. If I say the visceral obesity is the devil, then the hepatic fat is devil's father. If you have 100 grams of fat in your liver, you become a non-responder for physical activity. And why is this relevant? Because the only way to get glucose down, physical activity. The only way to reduce visceral fat is physical activity. But if you are non-responder to physical activity because of the presence of hepatic fat, it does not work. And this is the circulus viciosus in diabetes care. And we know all these patients would try, and don't succeed in losing weight and improving glycemia. Here diabetes starts, and here we diagnose diabetes. So we in the medical system come very, very late. And the true pathophysiology of diabetes is 20, 25 years earlier. And this is what we have to change. We have to flip our mind to think about how to address this challenge in our diabetes sector. So how can we act in this red paradigm to improve the quality of care for our people with diabetes? And this means we have to address visceral fat and hepatic fat and the interplay between both. Here the insulin signal transduction cascade, all the white blocks are switched on to modify this process. The red substances come out of the visceral fat and block this process. This is insulin resistance, the common soil for many, many chronic diseases and common diseases. And if we go, I apologize for the German slide, if we look deeper into it and into the liver fat aspect, here you see people, NAFLD, we can use synonym as MAFLD, people who don't have liver fat and people who have liver fat, and then separate by obese and non-obese. You see the obese, and here you see insulin resistance. The obese person without liver fat has a better insulin resistance than the slim person, but with liver fat. And this is a drama, and this is what we have to change. But there's also a lot of hope in it. Taylor has shown if there's a lot of liver fat and a lot of pancreatic fat, they always go hand in hand. It destroys better cell function. But removing liver fat will also remove pancreatic fat and it will restore better cell function. And this may lead to a remission of diabetes. So how this means we have to get the liver fat away. How to get the liver fat away? And the answer is actually very easy. Fasting. If you fast for 2 weeks without eating anything, liver fat disappears. You can empty the liver from fat. The pathomechanisms are glucagon plays an important role in the liver, in the pancreas, but the important message is, and the challenge, fasting for 2 weeks may lead to a remission of diabetes for 50 to 60% of our type 2 diabetes patients. But where is it coming from? Here you see 380,000 patient years on the slide, and it's tested if you drink one soft drink per day for 1 year, what it does with diabetes risk. Water is safe. It's not increasing diabetes risk. Orange juice, 40%, Coke, 40%, Diet Coke or Coke Zero, 60%. How can this be? And the answer are artificial sweetener, because they change the microbiome. So if you exceed a certain threshold of artificial sweetener every day, there are 38 available, 36 do change the microbiome. If you exceed a certain threshold, they change the microbiome. So other bacteria are invading our gut, and this per se is not a problem, but the problem comes from the bacteria because they produce metabolites, they produce fatty acids. So it's basically as their stool in our gut. They produce fatty acids we also incorporate through our gut into our bloodstream, and they accumulate in the liver, and they do developing fatty liver disease. So the change of microbiome is the trigger for getting fatty liver disease, and this makes us becoming a non-responder for physical activity. There are also other aspects in terms of how to change lifestyle. If we talk about patients with diabetes and obesity, we are not deciding as physicians about the lifestyle. It's purely quality of life for our patients. And there are also strategies how to change lifestyle, separated in motivation, action, and maintenance. And there are techniques how to use to help the patient to change lifestyle. This is also a challenge in talking to our patient to address this, to support the lifestyle of our patient. But there is new development. Smart health will disrupt our way of how to do diabetes care. And becoming president of IDF, this is one of our mission. I want that the IDF, the International Diabetes Federation, is in the pocket of every diabetes patient worldwide. Because here you see gray, how our anti-diabetic drug lower A1C, how lifestyle, and how old, middle old and young digital tools lower A1C. So how can a young digital tool, what is smartphone-based app, lower A1C? And how can digital intervention lower A1C? And the answer is very simple. We are in the pocket of our patient. We never have been so close to our patient than being in their pocket. And why should not be a modern diabetes care like this? Every one of us is taking 1,800 decisions a day. 450 are related to our lifestyle. If by using a digital intervention in the right moment, with the right intervention, with the right motivational strategy, with the right content, an impulse is set to influence only 10 of this decision per day, but over a year, we will change lifestyle and we will translate this into 10 kilogram weight reduction over a year. There are examples in Germany, because we are on the forefront in implementing this in the moment in worldwide, we can say. Vitadio is an app for type 2 diabetes, helping the patient to change lifestyle between the physician visit, using cognitive behavioral therapy to help the patient to change lifestyle, using artificial intelligence, that the patient is making photos from their food, and this information is used to improve the lifestyle of the patient for the next meal. Or Una Health, an app using glucose sensor and using the information from the sensor, again with cognitive behavior change therapy, to help the patient to improve, for example, low glycemic diet, or 1,2-DIGA, again using a sensor and being the diabetologist out of the pocket of the patient, having 6 areas where the patient gets treatment recommendation, and using the artificial intelligence to analyze the curve and being very precise in giving recommendation. So being the diabetologist of the pocket of the patient. But there, again, will be more. Think about using digital biomarker. So for example, here there are examples. Today, there are studies that if you use your analysis of your online shopping behavior, AI can identify the start of hyperglycemia 3 months actually ahead of the start of hyperglycemia. 4 months earlier, they can diagnose even a depression. So this is becoming interesting. I'm actually thinking we should use this information to the benefit of our patient. So imagine there are digital biomarkers, and we have to qualify these biomarkers. They don't exist yet. The biomarker exists, but not in the diabetes sector. And bringing these biomarkers together in a kind of assessment, visualizing this back to the patient, but also using AI, analyzing this for prevention of diabetes, I think everyone would say, this is cool, this is fine. But maybe also for therapy. So imagine identifying diabetes risk by using digital biomarkers, using digital health application to help the patient to change lifestyle. This can work even without visiting a clinic. And now every one of us says, oh no, we don't want. But think about regions like Rwanda, where there is a good digital infrastructure, but a lack of physicians. And there are many regions like this in the world. So could this be an improvement in the quality of diabetes care? Why should not digital diabetology look like this in the future, or like this? And at the end, I want to come again to the fasting. Not eating for 2 weeks without eating any kilocalorie, water diet, will have the potential to lead to a remission of diabetes for to 60% of our type 2 diabetes patients. We know that eating less is healthy. You could say eating nothing is maybe even more healthy, at least for 2 weeks. Why is it so powerful? In my eyes, this is the fastest gain of health because you reset your microbiome, and you totally abolish the liver fat content. So tackling the roots of diabetes, you will achieve by 2 weeks water diet for yourself or your patients. Here are an example of patients starting at 97 kilogram and leading to 87 kilogram in 2 weeks by the power of developing a ketosis. And if you fast for the first 4 days, the body is burning all the glucose, and then it's switching to burn proteins or fat, protein from muscles or fat from the fat content. So if you lay in bed, it will break down muscle. But if you are active, if you are physically active, walking 10,000 steps a day, it will switch to breaking down fat. And you will burn about 350 to 500 grams of fat per day. And this fat is used to translate into ketone bodies. And the energy contained in ketone bodies is 80% more than in glucose. So it's a powerful energy content for our body. And these ketone bodies are mobilized first in the pancreas and in the liver because glucagon is present there. The stepbrother of insulin helps us for ketogenesis and helps us to empty pancreas and fat from the liver. And here you see an AGP of a patient after fasting, and it's a flat glucose curve seen as with the daughter I said here at the beginning. Here you see MRI spectroscopy, and all this cloudy stuff in the liver is fat before fasting, and this is after fasting. And I think it does not need more explanation why fasting is powerful. How to do it? Drink 4 to 6 liters of water, empty your gut, walk 10,000 steps a day, and be careful with starting eating again 600, 800, 1,000, 1,200 kilocalories, and then you can go on with your normal lifestyle. This is the recommendation we are currently discussing at IDF in a group for fasting and diabetes to develop a new guideline for this future. So we will release this probably in Bangkok or in the following month after Bangkok. And on the physiological level, this is what fasting can achieve. So think about it. for your patient, for yourself, in your environment, this is an achievement, this is a challenge, but an innovation in diabetes care. Serving IDF means for me addressing the need of people with diabetes, doing prevention, improving digitalization, building a powerful organization, addressing the need of people, because this is what we have to do. Why IDF? Because I think the International Diabetes Federation can be a very powerful voice of people with diabetes, wherever they are. In my eyes, these people have the right to get an adequate care and preventive measure. And IDF's mission should be, or is, to do whatever we can, to do advocacy to achieve this in every country, in every region, worldwide. So people with diabetes have the right to deserve a better life. Is this enough? Don't forget the 10,000. Walking 10,000 steps a day will change diabetes risk. Using a pedometer will be the tool. Here is the old pedometer, but don't trust the physician. Here are 31 physicians on the slide. It's a German diabetes meeting. One is using the stairs, all the others the escalator. Airport in Doha, airport in Munich, airport in Dammam in Saudi Arabia, at diabetes meeting. These are we. So think about yourself being a good example for your patient, because then your patient will follow, walking 10,000 steps. From my side, a clear yes to address the challenges in diabetes care in the future, because we have the potential and the power to change the life of our diabetes patient. Let's do it. Let's work together to help our patient to walk away from diabetes. Thank you very much for your attention. And now I'm available to answer questions if they may arise.